All right. Well, my name's Tracy Evanson, and I'm a professor in nursing at University of North Dakota, and I am your moderator for the session. I am also a member of the Dakota Conference Planning Committee, so glad to see you all here. So I am pleased to introduce our speakers for our next session. Session number 7, just make sure that you're all in the right session on enhancing a transition to practice model with the residency program for rural nurse practitioners. And I will, as with each of the sessions, there is a pre-test and a post-test. I will, as soon as we get started, if you've not already filled out your pre-test, will you please do that? I will get that into the chat box in just a moment. And then just before we finish up, I will give you the link to the post-test as well. So our speakers for today are Mykell Barnacle and Debra Steen. Dr. Mykell Barnacle has a practice, teaching, and research interest in chronic disease management, health disparities, rural healthcare, and health promotion and prevention. She has completed research, publications, and practice improvement work in the area of depression and diabetes management, as well as rural healthcare education and competencies. These topics are particularly pertinent to the rural population of North Dakota and the effect that the lack of access to healthcare has on overall health outcomes and well-being. Joining her is Debra Steen, who has 24 years of experience as a family nurse practitioner working in family and internal medicine settings, including working for the last 20 years in a rural setting. In 2017, she developed the weight management clinic at Essentia Healthcare in Brainerd, Minnesota, which has expanded to include 3 providers now. In 2016, Ms. Steen and 3 colleagues initiated Essentia's Health Transition to Practice program for NPs and PAs in response to low engagement scores and high turnover of newly employed NPs and PAs. Both of our presenters have indicated that this presentation will not include discussion of any commercial products or services and will not include discussion of off-label and or investigational uses of any product or services and will not include trade names. So I hope that you enjoy their presentation, and welcome to Dr. Barnacle and Ms. Steen.
Okay, I think we are live. So this is really fun for us to be with you. Deb and I started working together a few years ago when we developed our residency program, and it has really been an excellent opportunity. We feel like we've learned a lot and would like to share a little bit of what we've learned with you. So our grant that funded this was a HRSA grant, and so we also learned a lot through that process, as is always the case. All right, so we are going to share with you a presentation that has a very long name, as we realize now. But hopefully that doesn't turn you off from learning a little bit about what we've been doing. So when we are finished, we hope that you identify components of an innovative rural nurse practitioner residency program, that you are able to apply some of the effective approaches for universities and healthcare systems to collaborate in order to support those learning needs of new nurse practitioner graduates, and then identify ways to support and enhance existing transition to practice models. So both Deb and I are here. My name is Mykell Barnacle, and so we'll be going back and forth a little bit since we get to be in the same room now. So as I'm sure many of you who are ingrained in rural care know, there's a disparity between the health status of individuals living in rural areas and more urban areas. Of course, that is due to many factors. The geographic isolation, of course, is a big one. It's not as easy to just hop in the car and go down the street to a clinic or see a specialist. Socioeconomic status also certainly contributes significantly to that disparity. There are also higher rates of health-related risk behaviors, and that is everything from job-related dangers to increased obesity and other more chronic disease-oriented health conditions, and then limited access to healthcare. And certainly there has been much written about this problem in the last number of years, and one strategy for combating lack of access and difficulty with getting some primary care would be to have more NPs in the rural settings. NPs are very well prepared to serve as primary care providers. In fact, 89% of nurse practitioners are prepared in primary care, and 68% of NPs practice in communities with less than 50,000 people. And we know, in fact, that Bierhaus article is great, that is referenced at the end in discussing all of the reasons that NPs are really positioned well to provide primary care in rural settings. They are more likely to live and stay in a rural setting for the duration of their practice career. They are more likely to be already embedded in that community when they embark upon their graduate education. They are less likely to have spouses who are have limited ability for jobs because of really high educational levels, which is often a deterrent for our physician colleagues. And so there are many reasons that NPs are well suited for the rural setting. Additionally, nurse practitioners tend to care for the underserved populations at a higher rate. And so many nurse practitioners work in clinics with that are federally funded or have other underserved populations. Because we are well suited to practice in rural settings, it also means that we need to be well prepared to do so. And I don't know that any nurse practitioners who practice in a rural setting will tell you that it isn't an easy job. I think the scope is very wide. They are expected often to have advanced knowledge of many different conditions and complexities. In fact, I was just visiting with a rural nurse practitioner earlier today who mentioned that she, really does a lot of internal medicine at the clinic that she works at. And, in an urban setting, many of her patients would likely be referred to an internal medicine provider, but because there is difficulty with access and transportation and all of the other things needed to make that happen, she ends up seeing a very complex caseload. Additionally, in our own research and also throughout the literature, we see that rural nurse practitioners use advanced skills and procedures more frequently. And so individuals are not as interested in, driving a couple hours to see a specialist for a knee injection or another procedure that could be done in the primary care clinic. New graduate rural nurse practitioners have particular difficulty integrating into this situation, partially due to some isolation, just the increased stress of it all, anxiety, feeling inadequate, and feelings of being overwhelmed. And so it can be kind of a double-edged, difficult situation when there's this high bar that is needed to care well for patients, but maybe not the confidence and experience that goes with that. All right, I think we are just going to scoot our camera because Deb is going to take over now.
Okay. So when we look at the preparing novice nurse practitioners for successful rural practice and review the literature strongly supports formal nurse practitioner orientation to kind of smooth that rocky transition from being the expert RN to now the inexperienced new nurse practitioner. Having such a orientation program does increase the nurse practitioner role satisfaction, the clinical competence, and confidence. We also found in the literature that the carefully designed postgraduate clinical training tailored to specific individual needs, such as the rural healthcare, provides the needed support during this transition time. So organizational support for transition to practice program. I'm going to take a step back a couple of years and talk about Essentia Health. And it was recognized several years ago that many of our nurse practitioners and PAs at Essentia Health struggled there, especially their first few years. Turnover was quite high. When we reviewed the literature regarding new nurse practitioners and PAs, we came across the transition to practice programs and the benefits of these, and we found that the literature was very supportive, and that the transition to practice programs tended to increase the skill and competence, the confidence, improved communication and collaboration, enhanced clinical judgment, improve the socialization of the nurse practitioner role, and this is especially important in the rural areas, increased role satisfaction, improved patient safety, enhanced recruitment, enhanced retention of nurse practitioners, and improved productivity. So we felt that a transition to practice program would be a win-win for everyone involved, the new nurse practitioner, the organization, and most importantly for our patients. So building a transition to practice program required getting organizational support. And this has been one of our challenges. And as we have shared our program, this tends to be a barrier for a lot of organizations is how do we make the case to spend the money on a program as this. So I'm going to talk a little bit about the history of what we did at Essentia and why we did it. In 2016, we had a turnover rate for our nurse practitioners and PAs of at about 14.5%. So the turnover rate of 14.5% at Essentia compared to the national average turnover at the time was which was 9%. So we were way above average. We also happened to do an engagement survey that year within our organization, and the overall engagement for nurse practitioners and PAs was quite low. It was way down at 8%. And when we looked a little bit closer at that data, the engagement for new nurse practitioners and PAs in their first 2 years of practice was all the way down at 4%, so really, really low. It was recognized by our leaders that the high levels of turnover as well as the low levels of engagement could have negative impacts on patient care, quality, and safety. So administration approached 4 nurse practitioners that were located across the Essentia markets, and they asked us to develop a plan to decrease turnover and increase engagement. The question they presented us was, how might the organization develop strategies that would increase retention and engagement, as well as improve quality, standardization, and consistency in patient care? We developed a detailed transition to practice program plan, and were given the approval to pilot it for 1 year. After this year, the plan was to examine the cost of the program and then look at the effectiveness at decreasing turnover and increasing engagement. And the big question, of course, would be would the cost outweigh the benefits? So in 2017, we started our pilot program in primary care across our Essentia markets. So it was in the Duluth area, the Brainerd area, and the Fargo area, in which new nurse practitioner and PAs were matched with a mentor in their department. We provided scheduling templates that had a gradual ramp up over time, as opposed to the previous plan of a couple days of orientation and then pretty much thrown into a full schedule. We had twice monthly virtual professional development sessions, which focused on Essentia cultural topics such as coding, quality measures, but then also more clinical related topics. And we trained mentors. We also paid mentors a stipend of $500 a month for their time, which was kind of a new concept for us. So what happened during that first pilot, that first year of our pilot program? We knew that the people directly involved in the transition to practice program, the clinic managers, the mentors, and the new PAs and NPs were very supportive of the program. They felt it was very successful, but we needed to look back at those 3 questions of turnover, engagement, and cost to secure that strong support we needed from our leadership. What we found out, turnover fell to 7%. Remember, we were at 14.5%, and the national average was at 9%. Employee engagement increased from the 4th percentile to the 50th percentile in our new nurse practitioners and PAs. Furthermore, we weren't specifically going to be looking at the productivity metrics as part of this program, but when we were asked to, we found out that the people who participated in the pilot program were more productive at 6 months and at 1 year than their matched cohorts who had not participated in the program. And in fact, the RVUs were increased to 23% at 6 months and 24% at 12 months. So a big increase in productivity as well. So we had to put that into a dollars perspective, taking into account decreased turnover, increased productivity, and then the other portion of the increased engagement. So the cost for the pilot program in 2017 included the cost for the transition to practice leads. There were 4 of us in each of our markets, plus the mentor stipends of $500 and the training, and that cost for 1 year was $438,000. When we were able to add up the amount of potential savings, it came to over $5 million for that first year. And so the bottom line, or the return on investment, came out to be at about $4.5 million. So now we had the attention and the support of our top leadership. And as the quote on the bottom of the slide says, without the strong support from top leadership, the business model will trump onboarding every time. So we were able to prove that the program would be beneficial. The Rural Residency Partnership is a partnership between North Dakota State University and Essentia Health. NDSU has nursing programs in Fargo and Bismarck, a BSN program, and also a family nurse practitioner doctorate in nursing practice program, which was established in 2004. Essentia Health is located in Minnesota, Eastern North Dakota, and Wisconsin, and has largely rural populations. About 40% of our primary care providers that are practicing in rural clinics are nurse practitioners. 2 years ago, the NDSU DNP faculty approached the Essentia Transition to Practice team, proposing that we apply for a HRSA grant to pursue a joint venture of developing a nurse practitioner residency program that would enhance the current transition to practice program. And we did receive the grant in June and immediately started to plan grant activities with our first cohort of residents starting in October of 2020. Our mission statement was to create a nurse practitioner residency program, expanding the Essentia Health's Transition to Practice program, further enhancing nurse practitioner skills and competencies, and improving the health of rural and underserved population. So the objectives. Number 1 was to expand the Essentia Health Transition to Practice program into the rural residency for the new graduate nurse practitioners. Number 2 was to identify, recruit, and retain the NP graduates to participate in a 12-month full-time rural residency program. The residents are full-time employees also at Essentia. Number 3 was to increase the residency competencies relating to mental health and combating the opioid crises. Number 4, provide trainings and exposure to telehealth and other healthcare technology. And this initially was kind of one of our, a bit more of a difficult objective, just because we didn't have a lot of opportunity for telehealth. But when COVID hit, we had lots of opportunity for virtual visits, and this became very easily attainable. The 5th objective was to target interventions and education around the childhood obesity crisis that are affecting the rural communities. And number 6, to provide the interdisciplinary opportunities for clinical growth and networking for residents. So taking a look at our transition to practice model, the conceptual framework pictured on the slide illustrates how the individualized orientation, the twice monthly professional development sessions, the departmental team collaboration, and the mentor all direct their energies to support the new nurse practitioner and the PA. And we feel that our transition program has been, our transition to practice program has been very successful, but adding the residency has made it even stronger and better. Okay. So adding the residency, the expansion of the transition to practice program, we have 20 additional clinic release days for educational opportunities for our residents. Part of the HRSA grant went towards subsidizing about 1/3 of each resident's salary for their first year. This was really helpful when we asked managers for these additional release days. We have developed clinically focused workshops which kind of hone in on the very specific clinical issues. We have some training modules, online training modules, and days of procedural training that we'll outline here in a bit. We have individualized specialty rotations. There are 7 specialty rotations. One of those is with an obesity medicine specialist because one of the grant objectives is childhood obesity. The remaining 6 specialty rotations are chosen by the resident, and it might be to meet a specific learning need, maybe a clinic need, or maybe it's a special interest of the resident. We have a monthly journal club. The first several journal clubs are led by the faculty at NDSU or myself. Then the last 4, they are each of the residents takes a turn at leading one of the journal clubs, and we just had our first one, which was a fun experience. And we added this year something, kind of a reflective journal conversation 4 times a year, where we have the residents join 2 of us online, and we talk about how things are going in their clinical practice. We don't really have an agenda, and it's just a time to share and support each other. And we found that to be pretty helpful for them. We have the 4 focus areas that are designated by the grant. And this includes opioids, which the residents attend a medication-assisted therapy workshop, and they get the MAP training. We have a day of behavioral health conference where they discuss the mental health emergencies that may present. The telehealth is one of the focus areas. Childhood obesity. Our residents do an online module that is sponsored by Obesity Medicine Association. and specializes in childhood obesity as well as their 1 day of observation. And we have 3 days that are contributed to clinical readiness. One is or 2 days are skills workshop, splinting, suturing, IUDs, and then we have an emergency preparedness day with topics such as mass casualty simulation, infectious disease, stopping the bleed. So several different activities. The resident selection, the residents, as I mentioned earlier, are employees of Essentia. They have recently all graduated from their nurse practitioner program. It needs to be within the last 18 months, and they need to be practicing in a rural area. So we have to exclude the sites of our clinics at Duluth, Superior, and Fargo, and Moorhead. They have to be in a rural area. We also look at clinics who've had a bit of difficulty with high turnover or issues retaining nurse practitioners. The residency is very much used as a recruitment tool. We have an information sheet that our recruiters hand out about the residency program. So all of our residents are assigned a mentor, and the mentors are the cornerstone of our transition to practice program. We choose our mentors very carefully. Our mentors need to exhibit competence professionally and also with interpersonal relationships. The mentors are team players. They demonstrate organizational values. We look for people who have good rapport and good relationships with the rest of the medical staff. The mentors commit to a one-on-one connection with the new nurse practitioner, providing consistency and continuity when there's questions or challenges. They commit to a 2-hour additional work every week for the next year. Again, this is a paid position, so it's outside of their regular work schedule. So their meetings may take place over lunch or before or after work. Weekly scheduled visits are used to address learning needs, to do chart review, talk about difficult cases, do some goal setting, assess progress, and just provide general feedback. The mentor also is asked to monitor the schedules, the new hire clinic schedules, because even though we have a schedule guide, a slower ramp up, sometimes patients get added in that aren't appropriate, or they might be adding too many in. So we want to reduce the risk of having too much, too fast, getting that burnout issue. We also have periodic check-ins with the regional transition to practice lead. So that includes the mentor and the new hire and the transition to practice lead at 1 month, 3 months, 6 months, and at 12 months. And we encourage mentors to reach out at any time if there's issues in between those meetings.
Okay, so we're going to switch back to me. When we were kind of coming up with the curriculum for our program, we knew just based on literature, but also from our own experiences with preceptors and with students in rural areas, that there were some educational needs that in the rural setting that maybe were a little bit different than they were in a typical urban setting. So actually NDSU faculty have sent out several times to our preceptors rural educational needs assessment. And we got some background, professional experience, orientation experiences, and skills and procedural competency information. Something that was particularly interesting was the difference in orientation experiences. And so certainly there were instances where individuals had a more extensive orientation, but there were also plenty of instances where individuals were hired and their first day on the job, they were on their own working in the clinic, and there was really no official onboarding, far less orientation. And so certainly the experience in kind of getting their feet under them varied greatly. And as we know, nurse practitioner experience often varies greatly in their nursing experience. So some maybe, had been nurses for 20 years previously, and some had less experience as nurses. And so a more standardized approach for orientation certainly may be helpful for improving that that transitional experience. When we ranked the educational needs of these are the rural preceptors, these were the rankings. So number 1, suturing or complex skin closure. Number 2, arthrocentesis. Number 3, punch biopsy. Number 4, casting and fracture care. And number 5, EKG interpretation and telemetry. And so as you can see, there is not necessarily a lot of, these are not highly advanced skills. These are not, really obscure things that these nurse practitioners wanted. These are things that are very easy to kind of help to facilitate this sort of education. And so this kind of base knowledge really helped us as we were developing our program. We also have all new, well, actually Essentia has their new advanced practice providers complete a self-assessment. And this is system-based. And so it can be, obviously these are conditions that are covered in general, and they rate their basic understanding or need more practice, all the way to understand and can perform independently. And so there are a lot of different things like that that are assessed, including, both conditions as well as some health maintenance information, pre-op exams and screenings, and then just miscellaneous skills like giving an ED or hospitalist report for admission. We also have our residents complete a self-assessment, and this is really kind of expanded from their self-assessment that they do for transition to practice to include more of those procedural and hands-on skills, as well as some soft skills like resilience and boundary setting. That becomes particularly difficult in a rural setting when often these new nurse practitioners are integrated in the community. They see their patients at the grocery store or at church, or their kids play together. And it can be a really tricky balance to strike when someone approaches you and is asking you for something, in your professional capacity when you are in a social setting. And so that boundary setting becomes particularly important. And then we, again, do the Likert scale with unprepared to very well prepared, and then the top 3 skills or procedures that they would like to get additional training. And so we kind of have a curriculum shell, but also have things that we are willing to trade in and out based upon the needs of our residents that particular year. So just a little bit more about some of our educational needs. So we have those clinically focused workshops, modules, and procedural training. The residency cohort does synchronous learning workshops. And so that has been difficult since COVID. We have not gotten together as much as we intended to. When our grant team reflected after our first year, we determined that both the residents as well as the faculty really wanted a little bit more interpersonal interaction with them. And so as it is set, we have a quarterly time where we get together. And so these have been more virtual this year because of COVID, but we do that in each market too. So everyone travels a little bit because, as Deb said, they're spread out throughout. We have people in Wisconsin and all over. So most of our work is done through Zoom or virtually, but we do get together a few times a year too. And that actually feels like a really important part of it to develop that collegiality too. And then we have our remote learning didactic and skills workshops. And so these are just advanced training. And, you know, it's so interesting because of course they got all of this as nursing, as NP students. But it is really different when you are the one calling the shots and when you are the one who has the patients that you need to apply this knowledge for. And so that first year of practice is such an important time for really solidifying some of that knowledge and skill. And so, you know, yes, they have had all of those didactic pieces previously and even clinical pieces previously, but it does take on a new level of kind of a deeper level of understanding when they are practicing themselves. Let's see, and then emergency preparedness. Again, speaking of kind of the high stress situations that can present, especially if they are one of or the only provider in a clinic or one of a few providers in a clinic, or maybe the only one covering an ER overnight or on a weekend. That new NP may be the one and only person who is making the call on things. And so some of those additional areas of focus. And then of course, specialty rotations. And those are also directed by the resident themselves. Based upon either a focus of their practice that they would like to build on. So, you know, it could be weight management, or we had a resident last year who did a lot of extra preparation and knowledge seeking about dementia care. So she was kind of the go-to person in her region for dementia care because that was something that was lacking in their area. I see we only have 6 minutes, so we'll kind of keep rolling through here. Here's, of course, a good picture, although that fishhook picture, if you are queasy, is a hard one to look at. But this is our skills day that we have with our residents. And actually something that we didn't mention, but I think is important to mention, is that our philosophy is really that we want it to benefit as many people as possible. And so we invite our mentors to as many things as we can. We also, if we have room, we have kind of caps for each experience, but we also invite other new APPs within the setting, within the Essentia system. And so it's more widely available and more beneficial. I see that Rhoda asked a question. Dr. Owens, in fact, we have cited you widely, so I'm happy to see a question from you. She was wondering about your engagement tool, Deb.
It was vital signs.
We also have a virtual mental health conference, and this is something that I think last year we had over 130 participants. And again, we opened this up not just to the residents, but also their all new APPs within Essentia, our NDSU students, Essentia APPs, and then preceptors that we've had too. This is just an example of our residency schedule. We run October to October, and that's primarily just because it takes a while to get hiring and up and running in most programs in this area. Graduate students in May. We do also do evaluations on all aspects, it seems like. So we have short surveys and extended surveys. We kind of do conference evaluation type things for short trainings, and then there's specialty rotations and kind of monitor our feedback. And so far we have gotten really excellent feedback from the students and have used it to change our program. It changed actually a lot from last year to this year, and we feel like based upon feedback we've gotten, we have a better program this year. Let's see, a journal club, again, that changed actually a lot from last year to this year too, to make it more discussion oriented. And some of them are, you know, ideas that maybe they haven't heard about before. And then some of them are just things like sinusitis. So it can be wide ranging. Here's just more examples of the evaluation. And I think you all have access to this. And these are more examples of just the students, I should not say that because there is a difference and it's important that we treat them differently, but their experiences, and generally they've been really well received. Let's see, Deb, I know we only have a few minutes.
Okay, so outcomes, year one, all 4 of our residents completed the 12-month residency and are still with our organization. And they their productivity met at least the 50th percentile of the benchmark, and they all reported very high satisfaction with the program. In addition to that, the health system administrators reported high satisfaction and were a little bit competitive than the second year in getting, they wanted residents. So we had to kind of pick and choose a little bit. And we are now in our year 2. Again, we're spread out kind of across 3 states. All of the residents are doing well clinically. They report high satisfaction with the grant rotations. We've added the reflective conversation theme. So this is the kind of our no agenda, just talking about how things are going. And we have started tracking themes a little bit, and I'll just leave those right there for you to take a look at. When the opportunities for improvement, I think 25 years into my practice, I still feel a lot of these. So I don't know that that ever goes away.
Okay, and finally, of course, the difficult point is sustainability. So we know it costs money. Right now we have a grant fund, but we are paying close attention to productivity, to retention, because hiring new primary care providers is not a cheap endeavor. And I think Essentia certainly recognizes that. And one other thing, just in our last minute, that I want to talk about is that, to me, it feels like healthcare institutions and academic institutions are really excellent natural partners. And I think we have both gained a lot from our partnership, and I think that employees as well as our students in our traditional program even have benefited from this partnership. And so there's a lot of room for mutual benefits with collaboration. All right, so in conclusion, we want NPs to practice at the highest level of their scope. These can be really helpful for smoothing that transition. It both promotes patient satisfaction as well as NP job satisfaction, confidence, and longevity. We have a lot of opportunity to work together as academic institutions and health systems. And, we're always growing and learning, but our curriculum has worked well as a template for collaboration.